First, I'd like to acknowledge that I live, work, and play on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. In this video, I'll provide an overview of where use of outcome measures fit in the care of people living with arthritis and undergoing hip and knee replacement surgery. I'll review some common terminology and acronyms and suggest what to look for in a good outcome measure that is to be used in clinical settings. I'll also introduce some ways to interpret the results of outcome measures to make sure that they are meaningful to both you and the patients. I'm hoping that watching this video will encourage you to explore and use the various resources available through the Total Joint Arthroplasty Outcome Measure Toolkit. Let's start with some terminology. Outcome measures are tools and tests designed to capture not only current functioning or physical performance, but also change over a period of time or over a course of treatment. They differ from screening tools or diagnostic or prognostic tests for that reason. Patient-reported outcome measures, or PROMs, assess a patient's health status at a particular point in time. PROMs are standardized, validated questionnaires that are completed by patients to capture their perception of their health status, their perceived level of impairment, and disability. PROMs can be generic measures such as the EuroQol 5D5L and therefore useful across a variety of health conditions, or they can be specific to a particular health condition or treatment procedure. They can also be specific to a body area, like the lower extremity functional scale or the Oxford Knee Score. PROMs can also be very patient-specific with items generated by the patient, such as the patient-specific functional scale. Information from PROMs comes directly from the patient without interpretation by someone else, and thus it largely eliminates clinicians' biases. They're often easier to administer on a regular follow-up basis as they don't require direct attendance or in-person appointments, although virtual care can address that to some extent with performance-based tests. Now, performance measures require the patient to actually perform a set of movements or tasks, which are then scored or measured or timed based on an objective measurement, such as the time to complete or the number of reps completed in a certain period of time. An example of this would be a repeated stands test. Performance measures provide different information compared to PROMs. PROMs and performance measures capture different aspects of patients' functioning, and therefore use of both types of outcome measures are recommended in routine clinical practice. This is the International Classification of Functioning, Disability, and Health, or the ICF. It's a framework for looking at health and health-related domains. And as functioning and disability of an individual occurs in a context, the ICF also includes a list of environmental factors and personal factors to consider. The ICF is the World Health Organization's framework for measuring health and disability at both the individual and population level. In this 2001 updated version of the ICF, it serves as a useful tool to help conceptualize where use of outcome measures fit in the care of people living with arthritis and undergoing hip and knee replacement surgery. Body structure and function refers to the anatomical parts of the body, such as organs, limbs, and their components. In the case of arthritis, we might be interested in things like pain and fatigue and joint instability. Impairments in body structure and function is the overarching term used when there are problems in this area, such as a significant deviation or loss of function. Activity refers to the execution of a task or action by an individual. When there's an impairment or limitation in this area, they're called activity limitations. Examples relevant to our patient population would be things like activities of daily living or walking speed or dynamic balance, again, measuring at the level of the individual. Participation refers to involvement in a life situation, and limitations in this area are referred to as participation restrictions. So this might look at someone's ability to work or volunteer or go to school or attend a place of worship. Environmental factors are also important to consider, such as access to social support, whether or not an individual's home or the environment they interact with is accessible, and whether they have access to health professionals. And personal factors that often come into consideration when working with our clients are their mental health, their self efficacy, their coping skills, and their health literacy level. Another helpful framework is the BC Quality Matrix. We can consider the assessment of treatment effectiveness as a key indicator or dimension in the provision of quality health care. Effectiveness can be measured through patient-reported outcome measures and performance-based tests, while the other domains are best captured through patient-reported experience measures, electronic health records, or maybe even administrative data. So, what are the benefits of routinely collecting patient-reported outcome and performance-based measures? To the patient, it ensures that they provide their perspective and identify issues and challenges that you might not otherwise identify through the history or physical exam. It can enhance patient provider communication and leads to shared decision making in prioritizing their symptoms or their impairments and areas to focus on. For clinicians, using outcome measures helps to inform the care and choice of treatment approaches. You can use it to assess the effectiveness of your treatment and identify clinical issues that warrant referral to other services or may need other resources. It, again, can enhance the communication with patients as well as your clinical colleagues as you're all speaking the same language. Decision makers, such as managers or directors or clinic owners, can use outcome measures to demonstrate the value of the program or service and how it contributes to the overall patient health outcomes. They can also use it to identify care gaps, compare across sites or conditions or subgroups, and it may even help them to prioritize where to allocate resources. A good outcome measure is valid, reliable, responsive, is feasible to use in a clinical setting, it's easy to interpret, it's acceptable and clinically meaningful to both you and to your patients. It should be freely available and appropriate for a variety of clinical settings and contexts, including outpatients, acute care, home care, rehabilitation centers. So let's look at each of these features now. Validity answers the question, does the instrument measure what it claims to measure? Does it address core domains or constructs for a given health condition or surgical process? That is, has it been validated and tested, in our case, for people who have hip or knee osteoarthritis or have undergone total joint arthroplasty? Face validity is just that. On the surface, does it appear to measure what it is intended to measure? Content validity takes a little bit closer look at, does it truly capture all the content or comprehensive lists of items that make up that domain of interest? For example, pain is more than just level of pain or pain intensity. It may be pain with different activities. It may refer to pain interference. And so a single visual analog scale measuring level of pain probably doesn't have good content validity. Criterion validity looks at whether the test or measure provides results consistent with a criterion variable or a gold standard. That's basically an effective measurement that is widely considered a valid measurement. For example, the gold standard for assessing aerobic capacity is VO2 max using a submaximal exercise test. The 6-minute walk test is a functional exercise test used to assess aerobic capacity, and it has moderate to high correlations with peak VO2, which is obtained during both submaximal and maximal exercise testing. And this correlation ranges from 0.6 to 0.9, which are considered high correlation coefficients. Criterion validity can be broken down into concurrent validity and predictive validity. Concurrent validity compares the results at the same time point, whereas predictive looks at the ability of a tool or a measure to predict some event in the future, such as the ability of a balance test to predict the likelihood of actually falling in the next 6 months. Construct validity is often tested when there's no gold standard available at which to compare the measure. It involves forming theories and hypotheses and then testing to see whether or not those theories are actually met or the hypotheses are met over the period of testing the outcome. Reliability now is the extent to which an outcome measure is consistent and free from error. It helps to identify whether a measure is trustworthy and can be used to monitor changes over time and among raters. All tests have some level of measurement error. That's the difference between the true value and the observed value. Sometimes that measurement error is what we call systematic. An example would be always rounding up your range of motion values to 5-degree increments. The errors can also be random, such as the second time you position the patient slightly different, or the angle that you're measuring range of motion from is slightly off, or the patient's a little more fatigued this time, and that introduces a little bit of error into manual muscle testing, for example. Sources of errors can be minimized with training, standardized procedures, and calibrating equipment. Now, the three most common and probably most important forms of reliability when using outcome measures in the clinical setting are test-retest reliability, which we use for patient-reported outcome measures, intra-rater reliability, and inter-rater reliability. Test-retest reliability looks at the stability of the measure with repeated administrations. For example, they may have someone complete the Oxford HIP score at baseline and then have them repeat it just a few days later when no change has occurred in their hip or osteoarthritis to see if the scores are consistent. Because you're going to be using that measure to assess change, you want to make sure that change has occurred because there was a true change in functioning and not just uncertainty in the scores themselves due to error. Intra-rater reliability is the stability of measures by one individual across 2 or more trials. If you were to test someone's or assess someone's range of motion at the beginning of an intervention and then again a few minutes later, would you get the same values? Are you using consistent positioning and directions and placement of your hands to capture reliable information? This is particularly important when you're going to be doing reassessments with the patient because you want to be confident that any change in the value is actually due to change in the person's functioning and not just measurement error on your part. Again, practice and training can help with this. Inter-rater reliability is the stability of a measure between 2 or more raters. And this is important in clinics or programs where one therapist might do a baseline assessment and a second therapist may do subsequent evaluations. So it's very important that the procedures are consistent and that the clinic has done training with those individuals to make sure they're all administering and scoring and reporting their values in a consistent fashion. As I said, all measures have some degree of measurement error, and we'll take a look at how that factors into the interpretation in a second. A highly reliable test should have high correlation coefficients, and these are measured through things like intra-class correlation, ICC, or kappa scores. Correlation coefficients in excess of 0.7 in most cases is considered good, and in excess of 0.8 or sometimes 0.9 are considered excellent. With using measures on individual patients, the higher the correlation coefficient, the better. So let's look at some glossaries of term. I've also provided a reference to a great resource looking at a glossary of terms from the Rehab Measures database, and I encourage you to take a look at that if you'd like some more information. So I talked about the error of measurement. The standard error of measurement is also referred to as the noise. It's the chance variation in the measurement. The smaller or less, the better, and the more precise the tool. For example, the standard error of measurement for assessing hip range of motion with a goniometer can range from 3 degrees for passive hip flexion to 9 degrees for external rotation. And therefore, any change in values within this range is not considered a true change. It's considered measurement error. Effect size is the magnitude of difference between two variables. And that's going to factor in when we talk about how to interpret any change in scores. For example, pre and post scores on the Oxford Hip Score can be expressed in original units from 0 to 48, or they can be expressed using standardized units, which is the standardized mean difference. We have some rules of thumb for interpreting the standardized mean difference as 0.2 equals small, 0.5 is a moderate effect size, and 0.8 or larger is considered a large effect size. Basically, an effect size of 0.5 implies the two groups or sets of values differ by about half of one standard deviation. And of course, standard deviation is the spread, how spread out the numbers are, or the distribution of the scores. So if you can recall from your Introduction to Stats course, one standard deviation captures 68% of the values. Two standard deviation includes 95% of the values. A 95% confidence interval, which is often included with some of the outcome measure scores, means that you're 95% confident that this range of scores includes the true value. And there's only a 5% chance that it falls outside of this range. So the more narrow the confidence interval is, the better. SRM stands for Standardized Response Mean, and it's a measure of effect size. Minimal detectable change is change that falls outside of measurement error or noise and corresponds with a detectable or noticeable change in the ability to do something or the value of interest. It's sometimes also referred to as the smallest detectable change. For example, the minimal detectable change for the 30-second chair stand test has been reported at 2.4 stands among patients with late-stage knee osteoarthritis. And one can be 95% confident that a change score equal or exceeding the threshold is true and reliable. Minimal clinically important difference is the smallest detectable change or difference that is evaluated as clinically important or noticeably important to the patient. It could change the patient's clinical management, or it's also, as I said, clinically meaningful to them. It can differ, though, based on the baseline score and the direction of change. So that MCID could be a measure of improvement or a measure of worsening. As an example, the MCID for the Oxford Hip Score and the Oxford Knee Score has been suggested to be 5 to 6 points. The standardized the smallest real difference, SRD, is basically the same as the minimal detectable change. It's an alternative when a tool's sensitivity to change is tested without a valid external criterion or gold standard of change. It's sometimes also called the error threshold. The minimal clinically important improvement, or MCII, is the smallest clinically important improvement over baseline, similar to the MCID, but it's only in the direction of improvement. And last term, PASS or PASS is the patient acceptable symptom state. It's the minimum cutoff value corresponding to a patient's satisfactory state. For example, the PASS for self-paced walking speed 1 year after a total knee replacement was found to be 1.2 meters per second. Values can differ for a lot of these measures, even within the same patient population, depending on the approach they use to calculate the values. You may read about some information such as anchor-based methods or distribution-based formulas. And newer publications actually suggest being quite cautious with the use of some of these change values when you're using them or applying them to individual patients. Now, our third measurement property to look for in an outcome measure is responsiveness. Does the instrument detect clinically important changes over time? It helps to identify whether it is sensitive to changes in the domain or the construct of interest over the course of time or with a certain treatment. Examples of responsiveness indices, or as I mentioned, the standardized response mean or effect size. Effect sizes can be shown in the original units, the actual points on a scale, or they can be normalized and pooled together using a common unit of measurement, so a common denominator. For example, in a systematic review of different exercise interventions for hip and knee osteoarthritis, the authors found moderate to large, so 0.5 or higher, effect sizes when data was pooled across 89 different trials. And an example of another, and this is shown in this table here. So they looked at 89 trials, and the outcome measure of interest was pain. They found effect sizes that range from 0.47, which is just below a moderate rating, all the way up to 1.11, which is considered a large effect size. And this is demonstrated in this, what we call a forest plot, showing that the intervention had clinically and statistically significant benefits over the control group. Another thing when looking at the responsiveness of an outcome measure is whether or not it has a floor or ceiling effect. The ceiling effect is when the instrument's highest score is unable to assess the patient's ability to perform, when greater than 15% of scores cluster around the higher end of a scale. It means it's going to be too easy for some of your patients to perform that activity, and you're not going to capture the higher functioning or the higher level performances. In this table here, showing the Oxford HIP score, it's showing in red the postoperative scores and in blue the preoperative scores. You can see the blue preoperative scores have what we call a pretty normal distribution or a bell curve, with only a few people, and certainly less than 15%, clustering around the upper end. And this scale has been normalized from a 0 to 100 scale. But you can see postoperatively, the scores are all skewed to the right, with well over 20, close to 20% of the patients recording the highest possible score on that scale. So that would have a ceiling effect. The floor effect is obviously the opposite of that, when all the scores cluster towards, or a good percentage of the scores cluster towards the lower end of the scale. There's a whole set of measures called the PROMIS tools that are widely used in research and are now being used more and more in clinical settings. And you're going to start to hear more about these. In fact, the University of McGill are looking at the clinical application of using these PROMIS web-based tools in real-world settings. They've been validated for a variety of musculoskeletal populations, including osteoarthritis and joint replacement. And they're actually derived from several different high quality measures with patient input and extensive testing of their measurement properties. They're highly responsive. And based on something called computer adaptive testing, which selects the next item in the tool, it minimizes the floor and ceiling effect. For example, in some outcome measures, there may be two questions about someone's walking tolerance. In the first one, it asks if you can walk 1 block, and the patient might score no or unable to do. The second question in that tool may say, how difficult is it for you to walk 1 kilometer? Well, the patient already said they couldn't walk 1 block. So it's not really appropriate to ask them if they can walk 1 kilometer. Computer adapted testing uses something called item response theory to pick the next most appropriate question to ask the patient. So it, in a way, customizes the outcome measure for the patient based on how they respond. And you're going to see more and more of this in outcome measures that are available and used in physical therapy. Feasibility looks at now the clinical feasibility of these measures. Some of them have been designed for research studies and they have very good measurement properties, but they're just not feasible to use in our clinics. So first of all, consider what is the burden to you as the clinician and to the patient to administer or complete and score and interpret and report the results of the either patient-reported outcome measure or the performance-based test. Consider whether the data that you need for it is readily available. Can you train a rehab assistant or kinesiologist to perform the test for you? Think about patient considerations. Do they have the cognitive capacity, the hearing, the vision to complete questionnaires or to perform a balance test, for example? Feasibility also looks at whether or not there's any costs or training required to administer a test or to score it or to interpret it. Some older outcome measures were very complex and had very detailed scoring algorithms that required actually you learning or taking a training course in order to correctly interpret and use. What kind of equipment needs to be done or needs to be available in order to conduct, for example, a performance-based test? What are the space requirements? Think about whether or not you would have space to do a 6-meter walk test, for example. Think about whether or not the test is safe and doable within your clinical setting and context. Consider the frequency of re-administration. Some patient-reported outcome measures ask patients to consider how well they are doing today or in the past week, while others ask them to consider the past month. If you're wanting to re-administer a tool every couple of weeks and the time or the recall period is the past month, obviously the patient's responses are going to overlap between measures. Consider whether there are any translated versions. In the toolkit, we make reference to the availability of translated versions of the patient-reported outcome measures, and we also discuss some of the administration options, such as whether they're available through pen and paper, a website, an app, or if virtual administration is possible. Acceptability and appropriateness also factors into feasibility. Again, it needs to be clinically meaningful to patients, the clinicians, and your team members. It has to inform clinical decision making, or there's really no value in using a standardized outcome measure. When used well, it can serve as an excellent communication tool between providers and serve as a common language base. Other things to consider are, is it culturally appropriate? Are there gender considerations? And could any of the questions in a patient-reported outcome measures be triggering? A good patient-reported outcome measures might also help to identify the need for other disciplines or services, such as occupational therapy to address some of the patient's activity limitations or participation restrictions, or mental health services. Now, interpreting scores is key because just providing a numeric value such as your score on the lower extremity functional scale is a 40 means very little to patients and probably doesn't mean much to you either unless you're using this tool regularly and have a sense of where that might fall amongst your other patients. The tools in the Total Joint Arthroplasty Outcome Measure Toolkit and supporting literature that we include provide a range of options to help you interpret or make sense of the results in a way that is helpful to the clinician and the patient. It might be a simple classification by the raw score. So, for example, on the Oxford Hip Score, a score of 20 to 29 says right on the tool itself, this may indicate severe hip arthritis. It is highly likely that you may well require some form of surgical intervention. Contact your family physician for a consult with an orthopedic surgeon. We can also look at our patient score and see if it meets or exceeds the minimal detectable change or minimal clinically important difference values, and thus interpret it to be a clinically meaningful or even important change. Just to jump back to another fairly straightforward way of interpreting scores, just looking at even the pre and post change and letting the patient know how much the value in a score has changed from the pre-test and the follow-up test can be helpful. Be cautious when presenting that as a relative change in percentage, because obviously a 2-point change on a, say, visual analog scale from 8 down to 6 would be considered a 25% improvement. But a 2-point change on a visual analog scale for pain from a 4 down to a 2, the same amount of change, would be considered a 50% improvement. So the baseline or starting point does matter, and sometimes that's why it's better just to present it in the original units of change. In a 2019 paper by King and colleagues, they suggested that even though minimal important differences, minimal detective changes, MCID values are derived from group data and can vary by clinical context and patient population, and whether someone's health is improving or worsening, these values can still be used pragmatically as a useful starting point with individual patients and to inform clinical decision making. Some other ways to help you interpret the data and make sense of it is to refer to reference values, normative values for a healthy patient population, recovery curves or trajectories, cut points and threshold scores, and patient acceptable symptom states. We'll go through each of these. In research, we're interested often in the difference between groups or the difference between the pre and the post test and look at p-values or the statistical significance of that difference. But in clinical care, we're interested more in the clinical significance and the magnitude or size of the difference. So let's apply an outcome measure to an individual patient and pull some of these terms together. Our patient is a 75-year-old female with advanced knee osteoarthritis, and she underwent a total knee arthroplasty 3 months ago. We used the lower extremity functional scale with her, which is scored from 0 to 80, with 80 being the highest level of functioning. At the start of her post-acute rehab program with you after her knee arthroplasty, her score was 40. 3 months later, her score improved to 51. This is an 11-point change. And we know that the standard error of measurement for the lower extremity functional scale after hip and knee arthroplasty is 3.7 points. But I've also seen it reported as high as 5.3 points in other patient populations. The minimal detectable change for the lower extremity functional scale is 6 points. The minimal clinically important difference that the patient should notice is 9 points, and that's a fairly universally applied value across a number of different health conditions. So our patient improved by 11 points. That exceeds the MCID, so we can say it was a clinically important change, and we, of course, could ask her if she's noticed an improvement in her day-to-day function. We can also use normative values to see how close she is to others in her age group as she recovers from her total knee arthroplasty. This particular reference refers to a Dutch population, so it's not the Canadian context, and in females aged 70 to 79, where our patient falls. And for this group of patients, 59 points is considered the median value. So she's far below the median value for a healthy 70 to 79-year-old female living in the Netherlands, but she's made clinically important improvements since the start of her rehabilitation. Another term I introduced was the patient acceptable symptom state. So the minimal threshold that the patient is satisfied with, or the level at which they would accept functioning. In the case of the total knee arthroplasty, the PAS cut off at 3 months after knee replacement, which is about where our patient is now, is 37 points. So she far exceeds that at 51 points. So she has achieved the PAS level. Just to take a little bit further look at normative values, they're typically determined for the healthy population, often by country, and are categorized by biological sex and age. There are population reference values for the Oxford HIP score. They looked at 317 Australian patients and 310 Canadian patients that were actually based here in BC, who had no active hip pain, injury, or pathology. And for example, in the 80 plus age group, the Australian average for the Oxford HIP score was 44.45, whereas for the Canadians, it was 33.7. So the Australian average or mean score was significantly higher than the Canadian population normative values. And this speaks to why it's important to try to find, and why we tried to find with the TJA-OM toolkit, normative values in the Canadian context. We can also look at reference values again, and reference values typically refer to the patient population, so a large group of people with the same health condition or recovering from the same surgery. Hamilton and colleagues in 2015 published detailed reference values by gender, which I assume he means biological sex, and age group for the Oxford HIP score and the Oxford knee score. And this one looks at the Oxford knee score. So this is looking at pre-op values on the Oxford knee score. And you can see it's a fairly nicely distributed bell curve. The mean value was at 17 points. And if you were looking at these reference values, you could pop in where your patient score was. In this case, we said 29 points, and you can see where they fall within that patient population. There are also cut points and threshold scores that we can use to interpret the data, and they provide a quick guide as to the patient's risk of, for example, a negative outcome, such as a fall in the next year, or classifying someone's level of severity, or in the case of this picture, classifying someone's level of inactivity or meeting physical activity guidelines. Absolute threshold scores can set the upper limit, also above which no potential improvement is likely to occur. So a research study done locally looked at what cutoff point preoperatively on the Oxford HIP and the Oxford knee score indicated that they were not likely to improve or achieve greater function with a joint replacement, and found those cutoff scores to be 40 on the Oxford HIP and 41 on the Oxford knee score. There's more information in this article here on interpreting patient-reported outcome scores, and you might find that helpful too for further reading. The patient acceptable symptom state, the threshold or minimum threshold above which patients are satisfied with results, has also been reported for a number of the outcome measures in the toolkit. For example, the PAS values for that Oxford HIP score after hip arthroplasty at 3 months were 34, but went up to 40 by 1 year and stayed close to that at 2 years. So scores lower than that, patients might say that that's not acceptable and they're not satisfied with the results. Another example is with walking speed. 1 year after total knee arthroplasty, the patient acceptable symptom value for walking speed was 1.2 meters per second. Now we can look at that and also compare that again to normative values. We know that for men aged 60 to 69, that the normative or walking speed for self-paced walking is 1.34 meters per second. And this is the most common age group in which people are having hip and knee replacements. For women in the same age group is 1.24 meters per second. So we can see that the patient acceptable symptom state or value, especially for women, is getting pretty close to normative values, and that's what they expect to achieve within a year of having their knee replacement. So it's really important to think beyond the score. The numerical value means very little to the patient. You need to demonstrate the value in completing the outcome measure by reviewing the scores with them, looking at the individual items and how they responded. Have them prioritize the items, the actual questions on the outcome measure, and so you together can decide which areas of functioning, what aspects of pain to prioritize in your treatment. You can also use the individual scores on each of the items to help set goals or identify expectations around care. It's not just the summary value at the end that matters. You can help patients make sense of the scores, as I said, by using reference values, looking at normative values. If recovery curves with percentiles are available, map where they're in that recovery curve. Show them that they're doing great and that they're within what you'd expect at this point, for example, 2 months postoperatively. And use cut points and thresholds with some caution, because I'm going to show you on a slide coming up with walking speeds that sometimes revealing some of these considered cut points can be a little intimidating. So some of the things we considered with the toolkit and looked for extensively were the different modes of administration for each of the measures, whether they were available in translated versions. We considered aspects of cultural and clinical diversity, although there's very little information provided on that. We looked at gender and biological sex considerations. We also need to consider the reading level and health literacy required to complete some of these outcome measures. We consider the time frame or the recall period and highlight those when those were available. We also factored in how often or when to administer the tools, at what stage of joint replacement, preoperatively, in the short acute care stay, or in the post-acute phase. And we provided information on whether or not the performance-based test had been tested for remote or virtual administration. So let's take a little bit closer look for a minute at performance measures or performance-based tests. So again, rather than the patient's perception of their ability, these tests measure their actual ability at a given point. The same measurement property considerations apply: validity, reliability, and responsiveness. And feasibility is even of greater consideration. Excuse me. The other thing with performance-based test, of course, is safety, especially if it's a test you'd like to be able to administer or apply virtually. It's ideal to also have minimal detectable change, MCID reference, and normative values to help you interpret these tests. The Osteoarthritis Research Society International, or ORSI, recommends these core measures for patients with hip or knee osteoarthritis or undergoing hip or knee replacement. The 40-meter fast-paced walk test, which is acceptable to do as a single 40-meter distance, or 2 times 20 meters, or even 4 times 10 meters, as it is done in the GLAD program. The 30-second chair stand test, the time stair climb test, and these again are the core measures, and they also acknowledge and recommend use of the 6-minute walk test and the timed up and go. If you're interested in reading more about those ORSI recommended measures, there's a great reference here and a nice little guidebook. And if you're interested in how to apply some of these performance-based measures with your hip and knee replacement patients virtually, this is a wonderful manual that came out of the University of Melbourne. Normative values, as I said, are helpful again with performance-based measures. And this is an example of normative values on the 30-second chair stand test represented by men and by women by a breakdown of 5-year age increments. They talk about what the average score is and the range and what's considered below average and above average. So they really make it simple for you to interpret where your patient might fall in these values. And then reference values speak to other patients living with the same condition. So individuals with osteoarthritis awaiting a joint replacement of the hip or knee, the mean number of stands in those who do not walk with a gait aid, so they don't use a gait aid, was 7.3 stands. And for those who walk with a gait aid was 4.5 stands. So you could look at whether or not your patient was similar to what those reference values were for a large group of patients in a similar circumstance. And again, we have trajectories of recovery or recovery curves and thresholds. In this example, for walking speed, these mean trajectories are looking at the speed for revision with a straight line, as well as primary joint replacements over a 12-month period. The shaded areas represents the 95% confidence interval for those scores. And I've added the normative values for females in the red dotted line, age 65 and older, and for males, age 65 and older. So you can see here that after a revision arthroplasty, the walking speed continues to rise until about 3 months and then starts to decline slightly, and is always much lower than walking speed achieved a year after a primary total hip replacement. So if your patient's score fell somewhere in these gray ranges, this would be considered sort of normal recovery after a revision or a primary hip replacement. Now, these are threshold scores, and this is the one I mentioned that you have to use this information or share it with your clients with some caution, because some of these statements around cutoff points are pretty strong, such as the risk of death, hospitalizations, and falls if a patient's walking speed falls below 0.7 meters per second. So this graphic is fantastic. It's from Middleton and colleagues, published about 9 years ago, and it shows some really nice ways to help you interpret what this might mean based on different walking speeds. You'll recall that a year after knee arthroplasty, patients' acceptable symptom state, and often what we refer to as sort of the required ambulation or walking speed of 1.2 meters per second, has a number of different interpretation values, such as someone who can walk at that speed would be able to do their household activities, and they have increased independence in self-care. So these cut points are very helpful. It's really nice when a number of different studies have all been summarized onto one graphic like this. So what are the take-home messages? Ideally, we should be using patient-reported outcome measures and performance measures, since they capture different aspects of patient functioning. Patient-reported outcomes often improve sooner after a joint replacement, and we see a leveling off of scores by between 2 and 3 months, whereas performance-based measures often dip or decrease in the first month after joint replacement and then start to recover and don't level off until after 4 months. So it's also important to consider the timing of when you're going to use each of those measures. We should select measures with good validity, reliability, and responsiveness, and ideally, those measures or those psychometric properties should be specific to hip and knee osteoarthritis and total joint arthroplasty. It's helpful to inform your clinical decision making to explore the individual items or how patients responded to those individual questions on the patient-reported outcome measures, and use those to set goals and prioritize treatment areas. help patients make sense of the scores. Go beyond just telling them what the value or the result of the test was, but interpret reported change value with some caution when you're applying to individual patients, because a lot of those MDC and MCID values were based on large groups of patients, and they don't always apply to the individual patient standing in front of us. And when possible, use Canadian normative values. The clinical context does matter. This is a list of additional outcome measure resources that you can refer to and that were used to help us with filling out and populating each of the interactive PDFs. Sorry, I couldn't think of the word there, that make up the toolkit. There's also some apps, and if you're using electronic charting or tools such as Embodia, Jane, and PhysiTrack, they have some built-in outcome measure tools that are fantastic that you can use to prompt your patient to complete in advance of a treatment, and will automatically score it for you, and even chart or plot the recovery or numerous administrations of the test, so you can track change and look at different ways of interpreting the results with your patients. For further information about patient-reported outcome measures specifically, these are some additional really good videos that I encourage you to look at if you'd like to learn a little bit more about using them in clinical measurements. And to learn more about the total joint arthroplasty and outcome measure toolkit and all the tools that we have vetted, reviewed, and recommended in the toolkit, please go to this website here. Thank you.